All right, everyone. Thank you so much for joining us.
Okay,
February 23rd.
Shireesha, now we're getting, you have something open in front of the slides and that's showing up as a black square on your top of your slides.
Okay, let me try this again. Sorry about that. Does that work?
Yeah, we can see the slide without the black box now.
Perfect. All right, I just won't touch anything anymore.
Great. All right. Thank you again, everyone, for joining us. This is Dr. Dhanireddy's talk on vaccine. Dr. Shireesha Dhanireddy is Medical Director of the Madison Clinic at Harborview Medical Center, the largest HIV clinic in the Pacific Northwest. She is a professor of medicine at the University of Washington. Dr. Dhanireddy earned her MD from Georgetown University and completed her residency and fellowship training at the University of Washington. She is board certified in infectious disease, internal medicine, and just recently addiction medicine. She serves as an expert HIV consultant for the Mountain West AIDS Education and Training Program, Project ECHO. Take it away.
Great, thanks, Amber. Thank you, everyone, for joining this morning. The topic today is immunizations for preventable diseases in adults with HIV. There's been some updates that I wanted to share. I've done a smaller version of this talk for the ECHO community, but given that there have been some significant changes, I wanted to go through those. Okay. Can you see my next slide there? Oh, there we go. So I don't have any conflicts of interest to disclose, except that I am pro-vaccine. So if you consider that a conflict, here's the mandatory acknowledgement here. Okay, so the objectives today are to review the current Advisory Committee for Immunization Practices, or ACIP recommendations for people with HIV, and then also discuss the newly updated OI treatment guideline recommendations for immunizations that are imminently available, and some key differences between those recommendations and the Advisory Committee for Immunization Practices, and then examine some contraindications to immunizations. I'm going to do this in a case-based format, and I encourage participation with the polling questions. All right, so to get started, a 42-year-old man with HIV presents for care. He has sex with men and is unstably housed. Which of the following is most action? 1, check hepatitis A antibody and vaccinate if negative. Vaccinate with a 2-dose series of hepatitis A. All right, give it. Okay, that's a good amount of responses. Can end polling. Wow, 50-50. I don't think that happens very often. So let's get to what to do. And I don't, some of these don't have a right answer. So I wanted to go through what the recommendations are. So here are the ACIP and OI guideline recommendations, this is a fairly dense slide, but I wanted to go through what this means and also what the A and B and 3 mean. So just to step back, A, B, and C are the strength of the recommendation by the guidelines. A meaning a very strong recommendation to do something. 1, 2, or 3 are the level of evidence. So 1 being the strongest level of evidence, typically a randomized controlled trial, and 3 being a very weak level evidence like case reports or expert opinion. So for hepatitis A vaccine, we know that all persons living with HIV should get a 2-dose series of the hepatitis A vaccine, or if you're giving the combined product of Hep A and Hep B, then the 3-dose series for those individuals without evidence of immunity. So the OI treatment guidelines also recommend checking an antibody response 1 to 2 months after completion. This is a little bit different than the general population for whom we don't check antibody responses for hepatitis A to see if they have adequate immunity. If negative, the recommendations are to revaccinate once their T cell counts are higher to see if you have a better likelihood of achieving that adequate immune response. Again, if people are if someone has a CD4 count less than 200 and they are at risk for hepatitis A, you should just go ahead and immunize, knowing that they may not have an adequate response and may need immunization again once their CD4 counts are above 200. We know that there has been significant hepatitis A in our community, and this was a bulletin from King County Public Health in July of 2020 when we were seeing hepatitis A amongst individuals predominantly unhoused, but also using illicit drugs. And there was a recommendation that was a little bit beyond the recommendations from the CDC, which were to vaccinate persons, consider vaccinating persons who had actually been previously vaccinated, and to check immunity for those individuals to see if they have IgG, and if they were not immune, to go ahead and repeat that series with an option of repeating hepatitis antibodies 1 month later to assess response. So you could also give 1 dose for people who have suspected waning immunity, particularly those who may have CD4 counts or who have a history of low CD4 counts, or others with chronic conditions. Raina Patel and Stephanie McLaughlin, one of our fellows, and Raina is one of our faculty members in ID, and Jason Simmons were inpatient when we had a little cluster of cases, and did note that people who had been immunized and with higher CD4 counts still developed hepatitis A in that cluster. We went ahead in Madison Clinic and recommended to consider immunizing people with HIV who are experiencing homelessness, sexually active MSM with recent STI, and have chronic hep C, even if their hep A antibody was positive, just because we were seeing these cluster of cases. So everyone was correct in their response in terms of how to manage this. For the most part, we are checking antibody responses, antibodies to hep A prior to vaccinating our patients with HIV. Okay, next case. A 42-year-old man with HIV who's living homeless, the same gentleman, is notified by public health that 2 people living in this tent community were diagnosed with hepatitis A in the last week. He does not know if he's been vaccinated, and he is not in routine medical care. Oh, something got cut off there. He denies, let me just move this over. He denies any symptoms, and which of the following is most appropriate? He does not need vaccine as he is asymptomatic. He should receive hep A vaccine as soon as possible, or he should receive a combination hep A and hep B vaccine as he is likely non-immune to both. All right, I think we have a good number there to end the poll. Oh my goodness, right back again with almost 50-50. So let's talk about this one as well. I'm glad that no one picked A because this gentleman is at high risk given his exposure and not knowing his previous vaccination status. So I wanted to just talk about management of hepatitis A post-exposure. So first, pre-exposure, we know that if people are going to travel somewhere that is hep A endemic, that we do recommend hepatitis A vaccination if they don't have enough time to get vaccinated and their duration of travel is significant and they're going to an endemic country, then we can give IgG for those individuals. For post-exposure prophylaxis in people with HIV who are non-immune, the recommendation is to give hepatitis A vaccine as well as IgG simultaneously in different anatomical sites as soon as possible after exposure, and ideally within 2 weeks of exposure. So this gentleman should get the hepatitis A vaccine and also IgG, which was not included in that response. The question about whether to give Hep A or the combination Hep A, Hep B. So remember, the Hep A vaccine series is 2 doses, whereas the Hep A-B combined product is 3 doses. So the amount of vaccine essentially in the 3-dose series is a little bit less. So if you want a more rapid chance or a better immune response, you would just give the hepatitis A vaccine post-exposure and not the combination product, so that you could get better immune response post-vaccine. Hopefully that makes sense. Essentially, what you're doing with the 3-dose combination product is splitting it across 3 doses versus the single antigen product, which is just over 2 doses. So the recommendation is to just give the Hep A alone in this situation. All right, switching gears here. Similar, where I'm going to use the same stem a little bit. A 42-year-old man with HIV who presents for care, has sex with men, is unstably housed. He is Hep B surface antibody negative, Hep B core antibody positive, Hep B surface antigen negative, and you decide to offer the following. So if we can pull up the poll. No vaccine, as he has past infection. Check Hep B DNA PCR to evaluate for chronic infection. Vaccinate with a 3-dose series of single antigen hepatitis B vaccine. Vaccinate with 2-dose series of Heplisav. All right. Okay. A little bit more favoring for checking hepatitis B DNA PCR to check for chronic infection. So let's go through this and talk about Hep B vaccination. One more stem for this. You decide to give a 3-dose series of Hep B vaccine and check surface antibody 1 month later, and it's less than 10. What do you do next? All right, and poll there. A lot of split responses here, so this is great. So I'm going to go through hepatitis B vaccination for people with HIV. I just wanted to let you know that the Beehive study is recruiting soon. I haven't seen that it's open yet, but I think it's open imminently. And what that is doing is looking at Heplisav in people with HIV who have been non-responders to the traditional vaccine, or who are naive to Hep B vaccine and non-immune. So look out for that for patients who may be interested in the 2-dose 1 month apart series that really doesn't have a lot of data. The only data that we have so far is a single center retrospective cohort study that is about to be published in JADES in April, but all we have is the abstract so far, and it's from UCSF with 64 people with HIV who received Heplisav, an 81% overall seroprotection rate. And this is what's interesting, is that 84% seroprotection rate in those with prior vaccine non-response, which may be a very attractive option for people who have been non-responders in the past. So we'll await the trial data from Beehive for more information. I also wanted to mention that it's interesting in the OI guidelines, I wanted to point out a little bit of a difference than what we see with the general guidelines, which in terms of what level of protection is necessary. Typically what we look for is a titer greater than 10, which is a correlative immunity, meaning that that number has been associated with good protection against hepatitis B. Individuals, there is one study that looked at this in individuals with HIV, which prompted this recommendation in the OI guidelines, which is for individuals with isolated core hepatitis, core antibody that you vaccinate with one standard dose of hepatitis B vaccine and check the titers 1 to 2 months later. If the antibody titer is greater than 100, then no further vaccine is needed. If the titer is less than 100, then you should complete the whole series, meaning the 3 doses rather than just the 1 dose that was given, followed again by antibody testing. And if titers aren't available, some of your labs may not show that it's greater than 100. Some labs just report greater than 10. Then the recommendation is to complete the whole series rather than just 1 dose. So I did want to point this out. In terms of, and then here is the data from this study, with the bottom line being that those who achieved the surface antibody titer greater than 100 after 1 dose showed sustained levels of antibody, seroprotective antibody, versus those who didn't have 100 after 1 dose really didn't achieve that sustained antibody and needed that 3-dose series to achieve sustained antibody. This was a very small study with only 55 patients, but it was the only data that we have to look at that seroprotection level in people with HIV with isolated core antibody. With regards to checking Hep B DNA, we know that that we can have occult Hep B in people with HIV. There's not a standard recommendation to check hepatitis B PCR in all of our patients with isolated core. For those who you may have clinical suspicion or who are undergoing hepatitis C therapy, then or have Hep C co-infection, then it is reasonable to check hepatitis B PCR to look for occult infection, as we can see flares of hepatitis B when treating people with hepatitis C. All right. Okay. 42-year-old man with HIV presents for care. He has sex with men, is unstably housed. Would you offer HPV vaccination? All right. This one is a little bit surprising to me. So the majority offering hepatitis, not hepatitis, but HPV, human papillomavirus vaccine. I see some comments here, but I can't see them anymore. Victor, I don't know if there people had questions. Okay, all right. So it looks like the majority would give the HPV vaccine to individuals with HIV, even above age 26. So here are the recommendations from ACIP, which are consistent with the OI guidelines recommendation. So routine HPV vaccination is recommended. We know that ideally children should get it at age 11 or 12, but you can give it as young as 9 years old. And you can give it up to age 26 for those who weren't vaccinated at an earlier age. Unlike the general population without HIV, the 2-dose series is not recommended for people with HIV, and it's just the 3-dose series of the nonavalent vaccine, a similar timing at 0, 1, and 6 months. For individuals age 27 to 45 who have not been adequately vaccinated previously, HPV vaccine is actually not routinely recommended. ACIP has started making recommendations based on shared decision making, which can be really frustrating to a provider as we're trying to figure out to whom we should offer it. We should always do shared decision making about vaccinations, but the strength at which we recommend something is not going to be the same for something with shared decision making. So what are some factors that people use to decide if we should be offering it? So essentially, when the ACIP makes a recommendation for shared decision making, it means that there's not enough data at a population level to really recommend it uniformly across the board. And And the reasons for that, I'll just skip to this slide and then we'll go back, is that most sexually active adults have already been exposed to HPV, and although not necessarily all the HPV types targeted by the vaccine. At any age, having a new sex partner maybe is potentially a risk factor for getting a new type of HPV infection. And we do know that people who are already in a long-term mutually monogamous relationship are not likely to get new HPV infection. And we do know that HPV vaccination prevents new HPV infections, but it doesn't actually treat existing infections or diseases. So these are the bullet points that CDC recommends discussing with your patient with regards to risk, benefits, potential benefits versus lack of benefit for specific patient populations. I think for most of us who are seeing people with HIV, particularly MSM, who've had multiple sexual partners, the potential benefit is likely small. The risk is very minimal for this vaccine. It's not a live vaccine. There's not really a lot of side effects to this vaccine. So from a risk benefit, the risk is low. The benefit also may be low. And so having a discussion with your patients about this, one of the issues comes up about payment when it's a shared decision-making, and that can be an issue for some patients where they're outside of that routinely recommended age group. And so they may get a bill, but although that is not uniform, so checking with their insurance would be important. Just to go back, one of the other things that is important to highlight for pregnant persons, delaying HPV vaccination until after delivery, although pregnancy testing is not routinely recommended before administering HPV vaccine. There is as you can see, this is a C3 recommendation, and so meaning that it's a weak recommendation with very little no evidence essentially, or low evidence or expert opinion for patients who have completed a series with the quadrivalent or bivalent in the past. Some may consider vaccinating with the nonavalent to cover more HPV types, but that data are lacking in terms of this approach. And so this is, again, something that you may consider for patients who had been previously vaccinated with a bivalent or quadrivalent vaccine. All right. 56-year-old woman with HIV, it's undetectable, CD4 count 260, presents for a pre-travel visit. She last received meningococcal vaccination 10 years ago. She plans to travel to Gondor in Ethiopia, on the western part of Ethiopia, in April. Which of the following is the most accurate regarding meningococcal vaccination? She should receive both the meningococcal ACWY and MenB vaccines at least 10 days prior to travel, and then another dose at least 8 weeks after first doses. She should receive the quadrivalent vaccine at least 10 days prior, and then another upon return. Meningococcal vaccine is not needed as she had already been previously vaccinated as an adult. All right. We can stop the polling here. So slight edge towards just the quadrivalent, but a number of you also picking both types of vaccine. So let's talk about meningitis vaccination here. Okay, so the ACIP recommendations are pretty clear, as are the OI guidelines recommendations, is to administer the quadrivalent meningococcal vaccine to all persons with HIV at least 2 months or of age or greater. And that's the quadrivalent vaccine. There's 2 types that are available. And that's an A3 recommendation based on, so the strength of recommendation is high, but the level of evidence is low. Really, the level of evidence comes from epidemiologic studies that show that people with HIV have a higher incidence of meningococcal disease compared to the general population, so thought to be just an increased risk. For people with HIV receiving primary vaccination, 2 doses 8 weeks apart, if you've been previously vaccinated, then it's every 5 years throughout life. I know that in our clinic, this repeat vaccination, sometimes in some cases, the primary vaccination, is not necessarily being adhered to, given that it's felt that the likelihood of getting meningococcal disease is pretty low. As we know, even though the incidence is higher in people with HIV, the absolute incidence is very low in adults in general. Serogroup B meningococcal vaccination is not routinely recommended for people with HIV at this time. So we think about other immunocompromised groups, specifically asplenic individuals, as needing both the quadrivalent and Men-B, but people with HIV don't need Men-B as just based on their HIV itself. So for whom is Hep B vaccination recommended? It's actually recommended for those who are at increased risk because there's been a recent meningococcal B outbreak in the community. If they're asplenic, like I mentioned, if they have complement deficiency, if they're on a specific monoclonal antibody that gives you 1,000-fold increase in meningococcal risk, or if you've had if your potential for exposure due to your work. There's 2 types of Men-B vaccine, and the same should be used for both doses. So if somebody with HIV has these other issues that may come up, then they would get Men-B as well. And there are sometimes outbreaks of Men-B in communities, and so it is important to be aware of those and consider Men-B vaccination in that setting. So these are the 2 types of Men-B vaccine that are available, and I won't go through too much. One is a 2-dose series and one is a 3-dose series for adults. So in terms of travel and meningococcal vaccination, so this woman would get meningococcal vaccine regardless of travel or not, given that her last vaccination was 10 years prior and the repeat is recommended every 5 years. But given that she's also going to the meningitis belt during the dry season, which is increased risk for getting meningococcal disease and being endemic in that area, the recommendation is to get the quadrivalent vaccine. Men-B is not what we see in the meningitis belt at all, and so it's not recommended as a travel vaccine. And so the vaccine is recommended at least a week or so prior to going to that area, for traveling to that area, so that you have appropriate time for developing protective antibodies. So this woman should get the quadrivalent meningococcal vaccine and not the Men-B. And she should continue to get the quadrivalent meningococcal vaccine every 5 years. All right. A 50-year-old man with CD4 count of 55 and undetectable HIV RNA presents with shingles and asks about the shingles vaccine. So what do you recommend? So he doesn't need the vaccine as he currently has shingles. He should not receive the vaccine as his CD4 count is below 200. He should receive the single dose live herpes zoster vaccine after the resolution of shingles, or he should receive the 2 doses of recombinant herpes zoster vaccine after the resolution of shingles. Okay. All right, great. Some of you picking should not receive because of CD4 count below 200, and some are voting for the live, and then most of you voting for the recombinant vaccine, so great. So this is an area where there's not agreement between ACIP and the OI guidelines. So I wanted to just show what the OI guidelines have, and this is these are recommendations that we came up with. Christine Johnston is actually the head of the OI vaccine guideline, OI guidelines for herpes zoster work group. And so we work together on these guidelines. And as I said, they are different from the ACIP guidelines, which currently do not recommend either product, the live or the recombinant vaccine for people with HIV, given the lack of data. So, however, we know that that's not really happening in real practice, and the majority of you did pick giving the recombinant vaccine. So the recommendations from the OI guidelines are for people with HIV age 50 or greater to administer the recombinant zoster vaccine 2 doses 2 months apart, and that's an A3 recommendation, meaning it's a strong recommendation without the data. Consider delaying the vaccination until the patient is virologically suppressed on ART and CD4 count greater than 200 to maximize the response, but you don't need to. This is not a live vaccine, and there's not a concern for, from a safety perspective, it's more from an efficacy perspective. And it's actually not approved for persons less than 50. This is a question that comes up frequently, because people with HIV who have had shingles even at an age younger than 50 or have had recurrent shingles, can we give the recombinant vaccine to those individuals? Currently, it's not FDA approved for those individuals. For people with HIV who have already received the live zoster vaccine, revaccination with the recombinant vaccine should be given. And that's really because as you age, the live zoster vaccine is not as, the efficacy decreases. And for older individuals in particular, the efficacy is significantly lower as you get into your 70s and 80s, if you give the zoster vaccine, live vaccine versus the recombinant. The recombinant, the efficacy at preventing incident herpes zoster is much higher in the 90s versus for individuals in the 70s and 80s who get live zoster vaccine, it's only about 38-39%. One important thing to note is that the live vaccine is no longer available as of a few months ago. It's no longer being made and has been overtaken by the recombinant vaccine. So you should see that no longer in the guidelines as it's not even available. Interestingly, there are data from Connie Benson, who looked at the live zoster vaccine in individuals with HIV, and there's a published paper about that vaccine showing that it is safe. There were even some people with CD4 counts as low as in the 50 to 100 group that received the vaccine, and it was safe in that group. So even though we have some limited data for that vaccine, it's no longer recommended because it's not available. All right. A 65-year-old woman with well-controlled HIV who's a smoker, she's received the polysaccharide 23-valent vaccine of pneumococcal vaccine. So let me just clarify that acronym. At age 50 and at age 55, so 5 years apart. She has not received the conjugate 13-valent vaccine. And she's 65. Which of the following would you recommend? No further vaccination, as she's already received those 2 doses. You would recommend the conjugate vaccine today, or shared decision-making regarding conjugate 13. All right, thanks. So the majority of you recommending the conjugate vaccine today, and some of you recommending shared decision-making. Great, so let's talk a little bit about pneumococcal vaccination in people with HIV. This is a great graph that I stole from David Spock, who's used it a number of times, that just explains this a little bit better than I could just put it, than I would in terms of words, because it is a little bit confusing. So for people with HIV who have been naive to pneumococcal vaccination as adults, they should preferentially get the 13-valent conjugate vaccine first, and then at least 8 weeks later, minimum of 8 weeks, get the polysaccharide vaccine, and then you can get the polysaccharide vaccine again 5 years later. After that, you can wait till age 65 to give the polysaccharide vaccine. For those who have already received the polysaccharide vaccine, then you have to wait a year to give the conjugate vaccine. And then after that, from a year, 5 years from the first polysaccharide vaccine, you can give another one, and again at age 65. So essentially, if you're under 65, you can get 2 polysaccharide vaccines 5 years apart, and then no more repeats until you're 65. And you should get 1 conjugate vaccine as an adult. Even if you've gotten one below 65, you wouldn't give it again after age 65. So some of you had chosen, shared decision-making. As I mentioned, all vaccinations and all therapies should be shared decision-making, but there is some language in the 2019 pneumococcal vaccination update, basically going away from standard recommendation for all individuals over 65. So this is excluding people with immunocompromising conditions such as HIV. So if you don't have HIV and you're over 65, it is no longer a routine recommendation to give the conjugate vaccine, and it should be a shared decision-making. And the reason that is because since they looked at incident invasive pneumococcal disease in the population, including age 65 and over, pre-introduction of that routine recommendation for conjugate vaccine and post, and essentially there was no difference in the incident invasive pneumococcal disease rates. And what the dramatic decrease had been attributed to even before the routine recommendation was put in was actually indirect effects of vaccinating children, leading to decreased invasive pneumococcal disease in adults and particularly older individuals. So it is no longer a routine recommendation in people without HIV. With HIV, every adult should get a conjugate vaccine at some point as an adult. And if it was before 65, you don't need to repeat that. You would not repeat the conjugate vaccine. Hopefully that makes sense. Okay, I wanted to go through some principles of vaccination. In general, for people with HIV, live vaccines are contraindicated if there's a low CD4 count, so less than 200. And so we think about MMR, varicella, we don't really give oral polio, oral typhoid, yellow fever, and really because of concern for potential vaccine-related illness. Although the likelihood of that is very low, it's still, in terms of risk-benefit, it's recommended to wait until their CD4 counts are greater than 200. And if there is a product like the typhoid vaccine that comes as an inactivated version, then to give that as a preferred vaccine. Timing is still important for people with HIV, that there's a decreased immunologic response to most vaccines. We know that there's a lot of data with hepatitis B vaccines, with influenza. Lower response, we know if low CD4 count, or even low, not just low current CD4 count, but even nadir CD4 count. Nina Kim had shown that in our patients in terms of response to hepatitis B vaccine, that nadir CD4 count was actually important, as well as a marker of developing seroprotective antibodies. And then we know lack of virologic suppression can also be related to poor immune response. There are some pros and cons for vaccinating earlier protection if you vaccinate early before waiting for their CD4 counts to rise. But then you may have to repeat that vaccination. And some of those recommendations that I mentioned did say, go ahead and vaccinate if there's increased risk, but you may have to do it again once the CD4 count is increased if they haven't had a protective response. So just some things about timing, and that is more of a risk benefit and shared decision making, and looking at the patient's potential risk factors for acquiring disease. And then vaccination based on CD4 count, the main ones I wanted to put in here, for most part, it's just the MMR and varicella that in terms of routine vaccinations that we wouldn't give. I put here herpes zoster vaccine, but on the ACIP recommendations, I will say that it's not included on either of those above or below. Here is the graph from the OI guidelines that kind of goes through, is similar to the ACIP, the way they format it, but some key differences in the way that it's visualized here in terms of ages, and then by CD4 count, and not just by CD4 count, which is what the ACIP does. So here in the blue, you can see that is shared decision making for HPV beyond the 26 years. Sorry, keeps backward. And then, and you can see here for men B, the yellow indicates that it's recommended if they have another risk factor that I mentioned before, like an outbreak or exposure. And otherwise, they are recommended. And then you can see in the red where there's a contraindication. For herpes zoster, it is recommended. And sorry, this graph is from ACP, but it kind of got stretched out a little bit. But this is the main difference that I want to point out here is the asterisk where it's gray, meaning there's just a lack of recommendation for herpes zoster. And so that is the key difference here in with HIV, with the OI guidelines versus the ACIP guidelines. Special recommendations in people with HIV. So hepatitis A vaccine, checking that titer 1 month post-vaccination, that's different than the general population. A Hep B isolated core, you give 1 dose and then check the antibody, and the goal titer is greater than 100 rather than greater than 10. And then meningococcal vaccine, we know that in general, adults in the general population do not get meningococcal vaccine, but people with HIV and others that have other immunocompromising conditions like asplenia would also get meningococcal vaccine. And then the pneumococcal vaccination, the routine recommendation for conjugate vaccine in adults rather than the shared decision making, and then the 2 doses of the polysaccharide vaccine that are repeated prior to 65 and then again after age 65, 1 additional dose. So I wanted to talk a little bit about one other preventable disease that is on everyone's mind these days, and that's COVID-19. And what do we know about COVID-19 vaccine and HIV? People with HIV are being included in the clinical trials. We don't have data yet specifically on efficacy in this population. I know that the Novavax trial was actively recruiting people with HIV. Other trials have included people with HIV. And we know that HIV is a potential risk factor for severe COVID-19 disease. There have been conflicting studies regarding people with HIV being at higher risk for morbidity, mortality versus standard risk. But we know that it is a potential risk factor. HIV is not a contraindication to COVID-19 vaccination. We should be vaccinating our individuals our patients when their time is ready and based on our phases and federal and CDC guidance. The efficacy of vaccine, like I mentioned, is unknown, but studies pending. So it is important to continue masking and messaging the continuum masking and physical distancing measures. The other thing I want to mention is that we do not want to give other vaccines within 2 weeks of COVID-19 vaccine. This has actually come up a number of times recently for the general population who are getting COVID vaccines having to be turned away because one of the screening questions is, did you get another vaccine within the last 2 weeks? So if we know that our patients may be going and signing up for vaccines soon for COVID-19 vaccines, just to kind of delay or think about the timing of these other important routine vaccinations in terms of the COVID-19 vaccine, and making sure that you're messaging that to your patients as well. So some take-home points, and then I can answer some questions. Remember to review immunizations during routine medical visits. This is part of our healthcare maintenance that we should be doing at every visit for our patients to make sure that they're protected against preventable diseases. We know that people with HIV have a higher incidence of vaccine preventable disease, specifically hepatitis A, B, meningococcal disease, and pneumococcal disease. And then, as I mentioned, some live vaccines are contraindicated in people with HIV. The live influenza, and I didn't really talk too much about influenza, is contraindicated at any CD4 count. And people with CD4 counts less than 200, we want to avoid those as listed below. There are a number of resources that I think are really helpful. The ACIP guidelines that are updated every February. The vaccine schedule is really helpful. And then the OI prevention guidelines has the table for those vaccines that I mentioned. The IDSA guidelines for immunocompromised hosts is a little bit old now, but does have a lot of narrative and text about the studies that do lead to the level of evidence that's in a lot of these recommendations, and is helpful when thinking about shared decision-making and other things if you want more information. I'm happy to take any questions. Thank you so much for your time.
So our first question here, I believe, pertains to information that you presented in the beginning of your talk, so I hope it makes sense. The question is, what about renal, in parentheses, double dosing versus not with Hep B vaccine?
Yeah, so one of the strategies for people who have been non-responders is to do double dose vaccination. So instead of 20, a 40 dose of Recombavax or Engerix, which is the standard Hep B vaccinations, and the renal dose, because that's the dose that they use, the double dose in hemodialysis patients to get a better response. So for patients who have been non-responders to a 3-dose series, and then you give an additional 4th dose, that has been my strategy. And if they still don't have a response 1 month later with a protective surface antibody level, is to consider doing a double dose vaccination. I have actually just been moving towards Heplisave in those individuals, even though that's not a firm recommendation, but that has been my practice. And you may want to consider enrolling your patients in Beehive, that study, for non-responders, to see if they want to participate in the study to look at that versus just getting Heplisave.
Great. Next question. If a patient is over 65 and has received Pneumovax, do you repeat Pneumovax every 5 years, or do you only give it once in patients over 65?
Yeah, that's a good question. So it's only once they're over 65. There's no further repeating. It's only been 19 to 64 that you would give it twice 5 years apart, and then again at 65.
All right. Individuals who are immune suppressed due to a kidney transplant or other transplants, is COVID vaccine or zoster vaccine okay to give?
Yeah, so there actually is a document that the SCCA created with others who work in the transplant population. The issue with these mRNA vaccines is not necessarily safety, but it's how effective they may be in this population. So there is some timing issues with regards to transplant. So generally not immediately post-transplant. I believe the time period is at least 3 months post-transplant. So delaying the vaccine after that period of during that period of very heavy, intense immunosuppression post-transplant, and then giving the mRNA vaccine. Again, not a lot of data in terms of how effective it is in that population. We know that the Pfizer and Moderna vaccines are 95% effective in the clinical trials, but they did not include these types of patients with severe immunosuppression. So we don't really know. The shingles vaccine, again, similar, we wouldn't want to, it would be a timing issue post-transplant. And then again, we wouldn't want to give those vaccines together. We want to make sure that they're timed apart.
Okay. Why isn't there clearer and stronger guidance about recombinant VZV vaccine, Shingrid, in those with CD4 under 200? It seems like the risk-benefit ratio is in favor of vaccination.
Yeah, so in the OI guidelines, you can give the recombinant shingles vaccine at any CD4 count, but you may consider waiting until it's over 200 to have a better immune response or until they're undetectable. The ACIP guidelines do not have a recommendation for herpes zoster vaccine at all, and that's due to the lack of data. And so in people with HIV, so they have left it blank given lack of data.
All right, I believe that's all for the Q&A.
Thank you so much, everyone. I'm happy to answer questions. I think most people in the ECHO community probably have my email. I forgot to put it up here if you have any questions that come up after. All right, thank you so much for your time.